to introduce
This meeting is being recorded.
a good friend and colleague, Dr. Kira. Sahil is an associate professor of medicine and uh, interventional director of the structural heart program at the Mount Sinai Hospital. He's going to talk to us today about complex valvular heart disease, aortic and mitral valvular heart disease shock. Um, Something that we see a lot in the CCU, and it's a very interesting and upcoming topic. So I'm looking forward to hearing more about this. Thank you, Sahil.
Great. Thank you, Ivan. Thank you for the Department of Critical Care Medicine for inviting me. We work pretty closely, and I'm really humbled and honored to be a part here. Let's let this not be a one-way street. If you want to interject me anytime, please go ahead. So we'll talk about aortic and mitral valvular heart disease shock, a topic I feel is really close to sort of my heart. Got me really interested in the field of structural heart interventions back when I was a cardiology fellow. So these are my disclosures. Obviously, I may discuss a few off-label things, but for the most part, we'll be on label. The objectives are fairly simple. We'll talk about burden and outcomes, what we routinely see and how they present. We'll talk about types of valvular heart disease shock and how I sort of classify them. It may not necessarily be in textbooks or articles. How do you manage them acutely? What does acute care comprise of? And then, do we have any structural heart interventional therapies as a bridge or a definitive therapy for these patients? So let's start by this very interesting paper, and I think one of the best papers. Maybe we should look it up also. This is data from Cleveland Clinic, 11-year data, and they looked at 2,820 patients. And what they did was they classified these patients as these shock patients as valvular heart disease shock and non-valvular heart disease shock. And they excluded three sets. Number one, they excluded patients who had a mixed etiology shock, which was small 44 number, patients with incomplete or missing variables, and patients with severe functional MR with LV dysfunction, your very true heart failure or decompensated heart failure patients. And what they found out, they had 442 patients with valvular cardiogenic shock, pure valvular cardiogenic shock. And then they looked at what were the etiologies, regurgitation being the most common at 43%, stenosis at 36%, and mixed etiology at 21%. And how were these patients managed? So a majority of the patients were managed medically, 40%. Few went through surgery and very few went through percutaneous therapy. Now remember, this is 2010 to 2021. Chances are that all the percutaneous therapies happened towards the latter half or 2015 onwards, not really before. So it's a very interesting paper, and I want to go over certain results as we discuss the burden and outcomes. So how do these patients do, right? Patients come in diagnosed with cardiogenic shock. Most of these are 6 p.m. onward transfers. How do these patients do at 1 year compared to those without valvular heart disease? So if you have a patient in cardiogenic shock without valvular heart disease, they tend to have a better survival than patients who come in with cardiogenic shock and valvular heart disease. So if you have a valvular cardiogenic shock, these patients do not do well as compared to non-valvular cardiogenic shock at 1 year. So that's number one that we learned from this paper. Number two, how do the different valve etiologies compare? So it's a very interesting aspect that, as a matter of fact, numerically, if you have tricuspid severity or tricuspid valvular heart disease shock, you tend to do worse. Mitrals do a little better, and aortics are in the middle. Now, the p-value is not significant. It just tells me that your sample size was so small that it does not really, if someone asked me what's the difference, I'd say really no difference if you look at the three valves. But numerically, there was a little bit of a curve separation towards 1 year. So something to keep in mind. Now, how were these patients managed? And you can see patients who underwent medical therapy alone did the worst. Patients who underwent surgery did the best. And patients who had percutaneous therapy were somewhere in the middle. So what does this tell me? This tells me very simple thing. There was a big selection bias. Patients who underwent surgery were in the early stages of shock. They had good substrate for therapy, and the surgeons quickly picked them up. The patients who underwent medical therapy were most likely made sort of quasi, they had multiple comorbidities, they were on this hospice palliative track or whatever it may be. So you have two ends of the spectrums where there's a cherry picking with the best cases for surgery, and then there's these worst cases where no one wants to touch them or the anatomy is really bad. You just let them be. So obviously there's a disparity. But what's interesting is that the percutaneous therapy did offer an incremental benefit over medical therapy alone. Now, yes, slightly inferior than surgery, but did offer some empiric benefit. What about valvular lesions? If everyone remembers from their days in residency, when we were taught about managing patients in pregnancy, stenotic lesions do not do well. Regurgitant lesions can be managed well. So whenever you have a stenotic lesion as a primary valvular cardiogenic shock lesion, the survival probability goes down. Mixed disease, slightly worse. Regurgitation, not that bad. So few key takeaways is that it's common. You tend to do more surgery in patients who are otherwise able to get surgery. There's a selection bias. If you leave them be, they don't do well. Percutaneous therapies offer a good segue or a bridge between the two. And then stenotic lesions need to be managed more aggressively, and you can potentially manage regurgitant lesions by themselves or by MCS or inotropes or whatever it may be in your medical care armamentarium. So as we go over this, let's talk about types of valvular heart disease shock. Now, again, this is my classification. This is not something you'll find in books. I like to keep things very simple because there's limited brain cells I have. So first thing is primary or native valvular heart disease shock. And this is what I classify as any acute regurgitant valvular lesion and decompensated stenotic valvular lesion. Stenosis is not an acute thing. Stenosis is a progressive thing. It's when they decompensate and present to you, they'll present with shock. Regurgitation can be very acute, and that's when they present to you with shock. So this is primary, native, nothing to do with anything else. The second type is the bioprosthetic failure or mechanical valve thrombosis. Entirely different therapy, entirely different strategy, right? But number three, very commonly we see is iatrogenic or interventional. As we are sort of accelerating in this space of structural heart interventions, we see iatrogenic and interventional has become a sort of non-negligible part of these patients coming to your CCUs or critical care units. Now, what happens? You could have acute severe AI following a balloon aortic valvuloplasty, right? You could have acute severe MR following a BMV. There's a rheumatic patient going for the second BMV. You balloon the valve and boom, you have acute severe MR. You can have acute coronary obstruction, annular rupture, or refractory VT during TAVR. What does it do? It stuns the LV. You have a wide open MR. So this becomes then not only an event, but also a valvular associated shock that takes time to recover. So very simply put, this is how I define valvular heart disease shock. You may find different, 10, 15 tables in books and everything, but I like to keep it simple. Primary, bioprosthetic, iatrogenic. Happened on its own, previous valve, we did it. So next slide. How do regurgitant lesions manifest acutely, right? This is an old fellow of mine, Bernard, was at Columbia, very smart kid, right? And he wrote this paper, and I really liked it. I think it's one of the best papers I've read. And it's very simply put, when you have acute MR or acute AR, your ventricle and the atria does not have time to adjust. There's no chronicity for it to adjust or adapt. It's a shock, right? So if you have the mitral regurgitation and happened acutely, what happens? Your left atrial pressure just shoots up. You have flash pulmonary edema, become really sick, hypotensive, hypoxemic, the works. Now, in the same situation, if you have a chronic MR, patient has chronic moderate MR for a very long time, the left atrial pressure does not really increase that much. Even if it becomes flail at some point, it won't rise as much as acute MR. So whenever you have acute MR, chances are the patient is going to have a rough course or a rougher course and needs therapy faster. Similarly, acute AR. Now, aortic valve, for the most part, very competent. With endocarditis, with iatrogenic manipulation, you can have AR, you can have perforation of these leaflets, a lot of connective tissue disorders, bicuspid aortopathies. If you have an acute AR, the LVEDP just shoots up. There's no time to compensate at all. And these patients become very sick very fast. So whenever you see acute MR, acute AR, act appropriately, act swiftly, because chances are you're fighting against time. Chronic MRs, chronic ARs, when they present to you acutely, yeah, you can manage with medications. You can spend some time calling, your MCS team. But acute AR, acute MR, I think needs a quicker fix rather than watchful waiting. Now, what about acute management? So again, this is a great slide and a great figure from that paper. So I sort of divided into the four etiologies or the four mechanisms of failure. So let's look at mitral regurgitation. What helps in mitral regurgitation? Diuresis almost always helps. Diuresis is great. What about reducing your afterload? Works perfectly fine. That's why we put the balloon pump. What about heart rate? Does heart rate change anything? No chance, unless patient has dynamic obstruction, HOCM with SAM. Otherwise, heart rate does not change anything. What about inotropy? You may need to support these patients, so you may need inotropy at that point. So inotropy, diuresis, decrease your afterload. Fantastic therapies. What about vasopressors? If you need vasopressors, you can start them on norepinephrine, dopamine, and epi. Absolutely fine. How would you do any non-MCS or temporizing measures? Whenever a patient presents with acute severe MR, you want to make sure if there's ischemia causing MR. So angiography plus minus PCI, CIRC, RCA, big culprits. Always make sure it's not true ischemic acute MR, which can happen in ACS, either in a frank STEMI or a non-ST elevation MR. Now let's jump to the second regurgitant lesion, which is aortic regurgitation. Diuresis, of course it helps. Anything that reduces your LAP and LVEDP will work for you. Decreasing afterload, yes, it helps. Heart rate. So whenever we are doing a BAV or a TAVR, if patient after ballooning has severe AR, the easiest thing to do is increase the pacing rate. Easiest thing to do. So increasing heart rate helps patients with aortic regurgitation. Inotropy, yes, sometimes you need to support the LV. What about vasopressors? Same. Norepinephrine, dopamine, and epinephrine. And isoprotenolol rarely can be used to increase the heart rate, but now you can quickly put a pacemaker and get things done. What about stenotic lesions? So most common stenotic lesions that will come to you in a decompensated fashion is older patients who have severe aortic stenosis now have developed some sort of sepsis or UTI and now or a GI bleed, and now they're coming to you really, really sick. So what has happened is it's not that the aortic stenosis happened today morning, it's a decompensated hemodynamic state in setting of aortic stenosis, which is severe. So diuresis helps, reducing the afterload helps, heart rate almost no change. And inotropy, if you have poor LV function, absolutely helps. Vasopressors, if you have to use something, use phenylephrine or vasopressin. Vasoactive agents, almost no role. The best temporizing measure, if you can do it, is a balloon aortic valvuloplasty. That's why you see patients who have sort of quasi-mixed sepsis or GI bleed, and they're coming to us. We do a BAV sort of to temporize them. What about mitral stenosis? Not commonly encountered in America. I trained and sort of did most of my, early medical training in India. Mitral stenosis, very common. Rheumatic heart disease, very common. Pregnant females coming with, rheumatic heart disease. So diuresis, great therapy. Diuresis works in all four things. Afterload, no difference. You want to decrease the heart rate. Mitral stenosis is the only lesion where you want to decrease the heart rate. Aortic regurgitation, you want to increase the heart rate. Mitral stenosis, you want to decrease the heart rate. Inotropy has no role. Why? Because the lesion is above the ventricle. It's stenotic lesion, not going to yield. Vasopressors, if needed, phenylephrine is fantastic. So all stenotic lesions, you lean towards PV, phenylephrine and vasopressin. All regurgitant lesions, you lean towards the DEN, dopamine, epinephrine, and norepinephrine. What are the other vasoactive agents? You can use IV beta blockers, amiodarone, and digoxin. The slower the heart rate, the better time for filling, right? So, especially in more stenotic lesions. What's a great therapy? Balloon mitral valvuloplasty. Best therapy to do. Quickly relieves the stenosis, hemodynamics improve, patients tend to do better. Now, this is acute management where you will be involved for the most part. What about MCS? Does MCS really help in these patients? So this is my MCS strategy, and I've kept it very simple. Aortic stenosis. First step, do a BAV. Open that valve. If need be, you can do an impella. There's a misconception that you cannot do an impella in aortic stenosis. The IFU for impella says if the valve area is more than 0.5, you can do impella. No issue. Once you've done a BAV, you've opened that valve up, you can put an impella. Now, what if there's RV dysfunction? When there's RV dysfunction along with aortic stenosis, then you have to help the RV as well. So what can help? Either you do an RP impella additionally, or you do a tandem heart with the RAPA connection. Now, what if there's an oxygenation issue? So you do a BAV, patient has very poor right ventricle, you put an RP impella, and now the patient is extremely hypoxemic, you're unable to ventilate the patient. The best thing to go is go on a VA ECMO. All right, so this is my sort of strategy for aortic stenosis. For the most part, if you have oxygenation and RV problem both, go to VA ECMO. What about aortic regurgitation? We don't know. No one knows. No one knows how to temporize them. No one knows how to sort of help them. People have tried different things. They put impella, they paste them, they put medications on them. Nothing really helps. You may need to go straight to LAVA ECMO, which is a LAVA ECMO, sort of shunts the entire left system. And that's your temporizing measure when the patient becomes ready for some sort of surgery, or we can do an off-label TAVR in these cases as well. Mitral stenosis, PTMC, which is your BMV, or a tandem heart. So straight up, consider these patients for a BMV, do a balloon mitral valvuloplasty. If there's RV dysfunction, same protocol, use a RV support, whether in the form of RP impella or a tandem heart. If there's an oxygenation and RV problem, go straight to ECMO. So ECMO would always be your answer for oxygenation and RV problem. What about mitral regurgitation? Balloon pump, fantastic. One of the best uses of a balloon pump is acute severe MR, even more than CAD or shock. I think cardiogenic shock, otherwise, balloon pump has almost no role in 2025. But for acute severe MR, fantastic device. You can use impella. You can use for your RV dysfunction, same impella RP or tandem heart. If there's an oxygenation or RV issue, go straight to ECMO. So this is sort of the strategy I have in mind when I'm seeing these patients, and sometimes I get called to see these patients, that, hey, are we having an issue with RV alone, valve alone, RV alone, RV plus valve, or it's a global issue with oxygenation and RV, where the call is go straight to ECMO, don't even waste your time. Any questions so far from anyone? Everyone's awake, I guess. Okay. So, third aspect is role of structural heart interventions. So, let's talk about structural heart interventions, right? So, there are two roles. The first role is a bridge. Patients admitted to the critical care unit. Can I do something to make everyone's life easier and then get this patient ready for the best definitive therapy? Can I do something as a bridge to get them there? The other is, can I just do something definitive? Do it right now, patient will recover, we'll go home. So in order to discuss these two things, let's go over two cases, and please stop me. So I just want to make sure everyone is following me here. Please stop me to discuss the case. So case number one. This is a 72-year-old female admitted for shortness of breath and dizziness, found to be hypotensive and tachycardic. Systolic blood pressure is in 70s. She started on inotropes, Lasix, amiodarone. Mild respiratory distress. She's not intubated. Echo shows an EF of 15%, severe aortic stenosis, moderate to severe MR, moderate to severe TR, moderate pulmonary hypertension, severe LV dilatation. And there's also an LV thrombus. Lactate is 2.1, creatinine is 1, BNP is 12,502. Ivan, are you on the call?
Yes, I am. Sorry.
Okay, great. So how do you want to manage this patient? You go see this patient in the ER.
Short band, hypotensive, tachycardic, short nitro, Lasix, mild respiratory distress, severe AS, moderate, severe MR, moderate, severe TR. I would start them on anticoagulation. I would start them on some inotropes and try to diurese them and probably put them on a little bit of BiPAP and see if they warm up. And if not, think about maybe like something like a balloon or something for a little bit of support for afterload reduction. And
Okay, that's a great point. So Ivan has been called. He does all those great medical therapies, and someone calls cardiology, and they decide to do an echocardiogram. So let's look at the echo. So the echo shows the valve, aortic valve, is barely opening. There is profound stenosis. It's critical stenosis. There's an LV thrombus, and there's significant amount of MR and TR. And this patient has coarctation of aorta and bicuspid calcified aortic valve. So this is the echo. Now you're armed with the echocardiogram, lots of medical therapy. What do you do next, Ivan?
at Sinai, we would probably consider doing a BAV on the patient to try to see if the giving him as a bridge to a more definitive TAVR while we resuscitate.
Are you concerned about the LV thrombus?
Yeah, definitely. The LV thrombus is also not ideal to put wires in. It makes it definitely a little bit more high risk. I guess it depends on kind of a little bit more about the characteristics of the LV thrombus. I would definitely anticoagulate them. But if it looks more acute versus chronic and kind of stuck to the wall, but yeah, you guys are definitely not, it's going to make it hard to put in an Impella or an ECMO or something like that.
Yeah. So this makes the situation real challenging, right? So let's talk about it. So we have cardiogenic shock, severe low flow, low gradient aortic stenosis, LV dysfunction, LV thrombus, MR, and TR. Now, what are the three options? Emergent triple valve surgery despite the prohibitive risk. Prohibitive risk because of the STS today. It may not have been prohibitive yesterday. The other option is stabilization with a BAV followed by a high risk TAVR or surgery. And number three is medical therapy alone. So you have three options now. What do you think?
I would probably stabilize with BAV followed by high risk TAVR surgery. I think I agree with you that emergent triple valvular disease would not be something the patient would survive. And I think that medical therapy alone is probably not going to be enough. It seems like he's not doing well.
Do you think that the triple valve is true triple valve, or is it aortic stenosis causing this severe LV dysfunction, causing the MR and the TR?
Uh, I think it probably is a little bit of both. I think there's probably some underlying MR and TR, but the severe LV dysfunctions probably not helping. But I think that the either way, I don't think they're going to survive a big aortic surgery alone, let alone triple valve surgery.
Okay. What about an emergent TAVR in this situation?
Um, I mean, it's an option. I know we don't love doing emergent TAVRs. We're kind of we do a lot more BAVs as a bridge to TAVR, kind of medical optimization. I'm not sure.
Okay, great. So the first ever published paper on emergent or urgent TAVRs uh, was by us. And back in the day, 1 in every 10 TAVRs in patients above 65 were performed as urgent or emergent. Okay. Acute device success was high, and it wasn't really different from elective TAVR. But where did the patients do really poorly? The patients who were on inotropes did bad. Patients who had AFib or flutter did bad. Patients with oxygen dependent lung disease did bad. Patients on CP bypass or non femoral access did really bad. So, what it tells us is yes, you can do emergent TAVR, but it may not give you the best outcome. Also, there's a higher risk of stroke when you're doing a TAVR versus when you're doing, because there's more manipulation versus when you're doing a BAV. After this paper, there was another paper published by Dr. Goyal in European Heart Journal. Again, it shows that the outcomes of cardiogenic shock patients undergoing TAVR lead to death when they are currently on dialysis. That means higher 1 year mortality if they're on dialysis. They are profoundly sick. That means NYHA class 3 or 4, or they have previous ICD, which is a marker of LV dysfunction for the most part, if they have peripheral arterial disease or if they're immunocompromised. So yes, you can do them. Your acute outcomes may be okay, but these patients may not do well from the time of hospital discharge to 1 year. So yes, that's why emergent TAVR is rarely performed. Urgent, you can still do. So what did we do for case 1? Very simple. I did a balloon valvuloplasty with a sentinel embolic protection device, made sure I didn't flick the thrombus and cause a stroke. This was such a calcified valve, I needed a peripheral balloon just to get my BAV balloon in. This patient was taken off all pharmacological support after the BAV. We started anticoagulation and GDMT as tolerated. There was excellent LV remodeling with an EF of 40%, mild TR, mild MR, and resolution of the LV clot at 8 weeks. So had we sent this patient for triple valve surgery, now imagine the pump time for an already sick patient for 3 valve surgery. All this patient needed was a BAV, your MR and TR improved, you resolved the clot in 8 weeks, and then we decided to plan for a definitive TAVR using the 25 Navitor valve.
I think we took care of this patient together, Sahil.
Yes, that's why I asked you these questions. So this is what the coarctation looks like. You can see it's a bicuspid anatomy, very commonly associated with coarctation, extremely calcified valve, significant amount of stenosis and regurgitation. So we go ahead, do the transcatheter aortic valve replacement. You can see how constrained this valve is in this image. You can see, and there's significant amount of PVL around the frame. Post-dilated it, excellent results. It's been 2 years since we did this. Her EF is now 65%. There's no MR, no TR whatsoever. So we used a structural therapy as a bridge and a structural therapy as a definitive therapy in this patient with very complex valvular heart disease. Now let's look at a second case. So it's a 65-year-old male who underwent surgical AVR 6 months ago, had a 23 millimeter Inspirus valve placed, presented with sudden shortness of breath, hypoxic to the 50s and improved to 70s with CPAP, was intubated on the field, has HCV cirrhosis, but the MELD score is low, emphysema, former smoker, is on all the good cardiac medications, is intubated, saturating 90% on 100% FiO2, lactate is 2.7, elevated BNP, has rails, and also has a harsh systolic murmur. How would you manage this case, Ivan, or anyone, Dr. Gidwani, anyone who's around? Maybe Dr. Gidwani if he's around.
Well, if Umesh isn't around, I kind of can cheat since we already. Oh, Umesh is on, but I think this was my case as well.
My camera is not coming on, but here's the thing. Question is, what happened? Did the valve malfunction? Because it's too early for it to become calcified. So probably there was acute AR because one leaflet went flail, but it's a systolic murmur. So I'm really not sure what happened here. Um, so the first thing I would do is to find out what happened.
Yes.
So I'll take it from here.
Yeah, that's a great point, right? So you have a systolic murmur and a patient who is intubated on the field and is only saturating 90% of 100% FiO2. So some sort of a flash pulmonary edema with a systolic murmur happened, right? So the valve, aortic valve, may be absolutely fine. Maybe it's a red herring in your, board question. Maybe some other valve is involved here. Possible, Dr. Gidwani?
It's entirely possible, and it could be the mitral valve, it could be the tricuspid valve. I am really not sure why this happened, but it appears acute, and I'm not sure what happened.
Okay.
Is there a shunt or something, intracardiac that is doing this? I don't know.
Great point. So maybe we should get some imaging, right?
Correct. I'm
So Dr.
nodding my
Gidwani
head.
calls immediately for imaging,
Yeah.
and you have a whiteout of the lungs. The patient is borderline tachycardic.
Yeah, sorry to interrupt. I just need to point out that this is asymmetric pulmonary edema likely due to a posterior directed jet of acute MR.
Beautiful. Fantastic. So this is what's happening here. You have an acute anterior flail, posteriorly directed severe mitral regurgitation, absolutely acute, no chance for the LA to remodel, no chance for any compliance to take over, and this patient's pretty sick. So everyone agrees this patient is sick and needs help?
Yes.
Okay. So what do the guidelines tell us? The guidelines are fantastic. I love guidelines. Why? Because they tell us what to do. Unfortunately, the guidelines do not read the patient chart or see the patient. So the guidelines say prompt mitral valve surgery, preferably mitral valve repair if possible, is life-saving in the symptomatic patient with acute severe primary MR. So should we call the surgeon, right, Dr. Gidwani?
I would call Dr. Khera. This patient has just had a sternotomy and so on, and is too sick really to go to the OR. In the old days, that would be the only option. But
Yes.
today, we have better options.
Great. So this is an acute flail MR, 3 options: emergent surgery despite the prohibitive risk, stabilization with a mitra clip, followed by a high-risk definitive surgery, plus minus, maybe if we need to, and inotropes plus balloon pump and evaluate. So you have 3 options. What would you choose here?
Well, I mean, obviously, we have to stabilize the patient. This is very high risk. And today we have options. So, first thing I would do is a balloon pump, inotrope, and call structural team. It's a hard team decision. It has to be collaborative. The surgeons and the structural people have to talk and decide the risk benefit of each pathway. But while they are talking, as the ICU doc, I have to get a balloon pump in right away, a swan, inotropes, and stat emergent heartbeat.
Great point. So yeah, emergent surgery may not be the best or the ideal situation here, and the surgeon's going to say no for the most part. Inotropes and balloon pump work fantastic. We already discussed that. So stabilization with TEER followed by high-risk definitive surgery is not unreasonable or out of the realm, but what is the data behind it? So this was an interesting paper, Survival Following Edge-to-Edge Repair in Patients with Cardiogenic Shock. It was a propensity match analysis, and what did we learn? That usually, back in the day, patients would present and they would wait up to 7 days to get the mitra clip. That means for the first 6 days, they are getting medical therapy, acute MCS, balloon pump, Impella, ECMO, and those who make it, they get the clip. Those who don't make it, go to the morgue or prepare for funeral. So you waited 7 days in this older data for any sort of clip therapy, right? And there was obviously a lot of selection bias that you would wait if the patient was showing signs of improvement, but you're unable to take off the MCS, maybe you'll try microclip. But things have really changed, right? There has been a threefold increase in number of patients undergoing TEER in the last 5 years, and it's probably increasing even more. And patients with the TEER cohort stay a little longer because you've given them a chance to live. And patients who underwent TEER are also more likely to survive to discharge. Yes, we see that, yes, there was a little delay in giving them MTER, but they ended up living longer. They were able to be discharged, albeit at a higher length of stay. And they were also more likely to be alive at 1 year. But this was the older data. What about the newer data? So this was some newer data presented from TBT. This was 3,700 patients. The success rate of the procedure is 85%. 85% we can be successful. The mortality, there's a huge separation at 12 months between patients who did not get MitraClip in pure acute MR versus those who got it. And mortality or heart failure readmission was actually lower if you did the MitraClip, right? The biggest question that arises is the LA does not have time to compensate. So the biggest problem you have in these patients is that the annulus may be smaller than a routine chronic MR patients that we see. So when you try to clip or oppose these leaflets, the trade-off is mitral stenosis. Your gradients may go up. So what did we do in this patient? So we did the MitraClip. We got the flail, anterior flail. There was almost minimal residual MR. And the final result was a gradient of 6. So we left the lab with a gradient of 6. We expected that, yes, we will take care of the acute mitral regurgitation at the cost of some moderate mitral stenosis on the table. So it was safe to temporarily trade acute MR for moderate MS, at least get the patient off all MCS support. Balloon pump was explanted and inotropes were tapered off. Uneventful hospital course, and the patient was discharged home. So instead of taking 14 days to decide the fate, everything was done in 6 days because we had this percutaneous therapy where we could help patients. But the trade-off was you're taking care of the acute MR, but you're probably giving moderate MS on the table. When the patient ambulates more at home, it may become severe MS. So what happened? Patient comes to my office, the gradient is now 17, feels sick, feels short of breath, and we know it's pure mitral stenosis because of what we did. Now we use the therapy as a bridge so we can get the patient definitive surgical mitral valve replacement in a very controlled setting. This patient is now at home, he's recovered, he's more beefed up, and now we can get the patient ready for mitral valve surgery. Dr. Elishma, we did the surgery, beautiful results, and I'm seeing this patient in clinic for now 1.5 years, doing very well. So a lot has changed, right, in valvular heart disease shock. So first of all, you want to figure out if there is futility. When you see a patient with cardiogenic shock, whether it's acute onset or old chronic that has sort of worsened, first thing is to check for futility. Is this even viable? Then, like Dr. Gidwani said, fast reevaluation for persistent shock. You have to involve your heart team. You consider your MCS, multimodality imaging, consider valve intervention if appropriate, but you've got to involve your heart team. And then based on what pathology you have, you can go ahead and manage these patients. So really the field has completely changed now. How we used to manage these valvular heart disease shock patients back in the day when I was a cardiology fellow is very different from where we are right now. And I think it's only going to increase with time. So my key take-home messages are: it's not infrequent, it's associated with poor outcomes, watchful waiting in medical therapy alone is not beneficial, early initiation of valvular etiology and RV dysfunction hypoxemia-specific MCS is key. Prompt involvement of the heart team, which is your structural heart, coronary, CT surgery, and imaging, very important. And be willing to use structural heart interventions as a stabilizing bridge to more definitive therapy or pure definitive therapy. So thank you so much, and we are in time. Thank you.
To heal, those were two really amazing cases and really great saves that probably 15 years ago wouldn't have been alive and wouldn't have survived the OR. So thank you for sharing that with us. I'm happy to open up the floor to anyone from the audience. I know there's a lot of interesting topics and questions. So does anyone from the audience have anything to add?
I just have a comment that the structural heart team at Mount Sinai has really been taken to the next level with the addition of Dr. Khera, who is now the director of structural heart disease. And honestly, seeing what has happened in the last 5 years, we were here, this was in 2011, the Pivotal Trial Center for the core valve, and we were present at the beginning, so to speak. And I think that we are just getting started. I think there's a long road. We are, if I'm not mistaken, Sign, correct me, at least in one of the procedures, we are the leaders in New York City, and the other one just barely number two. So I think we're just getting started. It's going to be amazing.
Yes, I thank you so much. First of all, that's very kind of you. Um, when I joined Sinai 2019, I was interviewing in 2018 with Dr. Sharma, and I said, Dr. Sharma, you're number one in coronary. We have to be number one in structural. And I think that's the goal. My goal hasn't changed. The team is fantastic. Dr. Kinney, who is the head, the system head, and someone I respect and I've learned a lot from, a lot of experience. Gilbert, who's my surgical colleague, and obviously our imaging department. We have Dr. Stamlerakis and Dr. Lucy Safi, and everyone's always available to help out. And thank you for the kind comments. Really, we work as a team. Critical care, spearhead by Dr. Gidwani and Ivan, and really makes a lot of difference in our outcomes. I mean, you can't do it alone nowadays. It's a team effort.
Thank you for a fantastic look at a very niche area that is playing an extremely important role in management of cardiogenic shock patients with valvular disease.
Thank you.
Any other questions from the audience before we wrap up? Okay. If not, thank you, Sahil. It was a great talk, and we really appreciate it.
Thank you, everyone. Have a
Bye.
good day. Thank you.